5 seconds to start. Let's start.
Miyaguchi-san, are we live to everyone?
Yes, please go ahead.
Okay. Good evening and welcome to the Aperta Global Summit, comparing the U.S. and Japanese approaches to femoropopliteal treatment. My name is Tim Hale. I am in marketing for 𝐁𝐵RO in North America. And we have a very engaging evening and morning event for our Japanese colleagues today. We will start with introducing our physicians, and then we will go right into presentations on femoropopliteal treatment in the US and in Japan, followed by an introduction to the novel scoring balloon Aperta. Finally, we will do some case reviews in both the United States and Japan with a final discussion. As we kick it off, I am very excited and pleased to introduce Dr. Craig Walker. Dr. Walker is an internationally known expert in peripheral arterial disease. He has trained over 1,500 physicians in advanced peripheral intervention techniques. Dr. Walker also founded the Cardiovascular Institute of the South, which has grown to over 20 clinics across the south of the United States. He also serves as the chairman for the NCVH meeting and the clinical editor of the Vascular Disease Management publication. Dr. Walker, the floor is yours.
Thank you, Tim. Tim, may I have our slide? And so this is me on the left. I guess that's a little bit younger me if I were to guess. But I have here with me my partner, Dr. Pradeep Nair, who's really internationally known. As you know, he does live cases for courses around the world. And he's one of my partners here at the Cardiovascular Institute of the South. And later, he's going to be presenting some cases. And it's my pleasure to ask Dr. Kazuki if he would please introduce our Japanese physicians. And can we get that slide up? Thank you.
Sure. Hello, my name is 𝐼𝐞𝐚𝐭𝐮𝐫𝐞𝐝 from Osaka, Saiseikai Nagas Hospital, Japan. I'm a interventional cardiologist, so I do the PCI and the endovascular intervention. Today we have two, actually I am not a little bit young, but more younger operators from Japan. The first is Dr. Kojima from Tokyo Bay 𝐬𝐤𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬𝐬 cardiologist. And next one is Taku Toyoshima. Is Osaka Police Hospital, and he's also the interventional cardiologist. And they are one of the hottest and the most promising operators in Japan. So I'm very looking forward to share our trends and the cases with Dr. Walkers and everyone. Thank you.
Great. Well, I'm very excited to hear them speak here shortly because I've had the opportunity to work throughout Japan, and I've been very impressed with the quality of interventional work that's done throughout the entire cardiovascular space. And I'm very much looking forward to hearing what you have to say. So I was asked to speak about femoropopliteal treatment in the United States and where we are today. If I may have the next slide, Tim. These are my disclosures. Next slide. So the present indications in the United States for treatment of femoropopliteal disease is as therapy for critical limb ischemia, and often this is part of multi-level disease treatment. For disabling claudication, despite aggressive medical therapy, including cilostazol, structured walking programs, smoking cessation, and statins, that was not always the case, but right now, insurers are insisting upon this. And then finally, there's an indication for high-grade edge stenoses of covered stents. And the reason for that is if we do not treat those, they may otherwise fail and the entire vessel thrombose. Next slide. So the goals of SFA treatment are the same throughout time. We wish to establish a widely patent vessel with excellent blood flow. We hope to achieve long-term patency. We've not always done that. We hope to have no complications because we don't want to create a new problem. And finally, we wish to alleviate symptoms and, in the cases of limb salvage, to save limbs. Next slide. Now, there's been a dramatic shift in treatment trends in the United States. Right now, most of this care is not being treated in the hospitals, but rather it's moved to office-based labs and ambulatory surgical centers. And there's a lot of reason for this. It's much less cost. It's a better patient experience as there are not emergency cases making patients delay their schedule. It's less confusing to the patient because they come to one place and everything is treated at one time and there's no overnight stay. Next slide. Now, there has been a big change also in therapy trends. There's been a major shift to endovascular treatment first. And I know Japan has long held this, but now in America, more and more, we're seeing endovascular treatment first. There's a marked increase in atherectomy in an attempt to decrease the need for stents. There's increased use of drug-coated balloons and drug-eluting stents. There's an increased use of specialty balloons, such as lithoplasty balloons and focal force balloons. And there's been a clear decreased use of bare metal stenting because of problems there. Next slide. So what's driving the changes in care? Well, plain old balloon angioplasty, which was the gold standard for years, has a very high restenosis and reocclusion rate in the SFA. In-stent restenosis has emerged as a problem. I remember when we first reported in-stent restenosis in the legs, people said, well, they didn't see it. They didn't think it was a problem. I think now we all know that fractures and restenosis is a huge problem. And we're trying to get more and more away from that. Some would state that the reimbursement change, which has occurred with atherectomy, has contributed to the increased usage of atherectomy. I work in both hospitals and ASCs, and my use is the same in each. I do think atherectomy can play a role. I don't think it's necessary or appropriate in every case because it does also carry an embolic risk. And the other thing driving the change is hospital care is incredibly expensive, often 2 or 3 times more than patient in an outpatient setting. And we have real crisis in America in terms of healthcare costs, and outpatient therapy may help to address that cost. Next. So with that, I'm going to ask Dr. 𝐭𝐿𝐿 to present what he's seeing in Japan in terms of changing trends with treatment of femoral disease, femoral and popliteal disease. Dr. 𝐭𝐿𝐿.
Okay, thank you. Thank you, Dr. Walker. So, I learned very much about the situation is very different from United States and Japan. Usually, you mentioned about the cost of the hospital treatment, but in Japan, more than 99% of the intervention is, especially for the peripheral intervention, is done at the hospital, not in clinical. So, let me show the trends. Okay, I share my slides first. So my topic is about the femoropopliteal treatment trend in Japan. Focus on the device difference and the insurance system difference from Japan and the United States. So this shows the number of the femoropopliteal intervention cases in Japan according from the 𝐤𝐸𝐵T registry, the registry from the cardiologist registry. So the number is very increasing year by year, and the last year, 31,000 cases per year were performed in Japan. So this shows the transition of the finalized device in FP intervention according to the JEPT registry. Start from 2017. At this time, we did not have any devices like a DCB. Only we had a Gilbert PTX and only drug coated stent. And usually, actually, the balloon angioplasty is 54% and the bare nitrogen stent is 38%. This year, Viavan stent graft was launched in Japan. So this is the purple is the couple cents. Some patients start using this Viavan stent, and next year, 2018, a little bit increase, but only 3.5% was the Viavan stent graft. This year, two drug coating balloon was launched in Japan, Impact DCB and the Lutonix. So many patient operators started using DCB instead of the balloon angioplasty. And the next year, 2019, slightly increase of the usage of DCB. This year, we in Japan, three stents launched. One is a 𝐬𝐤𝐬𝐬𝐬𝐬 drug-eluting stent, and the two is a bare nitrogen stent, a super interwoven stent, and the biomimic 3D stent. So the usage of the drug-eluting stent slightly increased, and the next year the doubles with very increased to 23%. The most of these are the 𝐬𝐤𝐬𝐬𝐬 stent. Also, the usage of the DCB should increase up to the 40%. And next year, still continue the usage of the DCB little bit increasing, but the usage of the drug eluting stent little bit decrease because of the high rate of stent fear of the stent thrombosis and acute limb ischemia. So some operators hesitated to use the drug eluting stent. And this 2021, the Ranger DCB, the next second generation DCB was launched in Japan. And still the usage of the DCB increasing. And 2022, we had this is the first atherectomy device in Japan that the Jetstream was launched. And 2023 and this is 2024, this is the last year. So the percentage of the drug coated balloon is around 70%. Most of the cases were treated with a DCB, and 50% is a drug eluting stent. And this year, we had another new DCB, the Luminol, was launched. And hopefully early in next year, we have the new sirolimus eluting balloon, the solution. We will start using this. This is a trend in Japan. So let's focus on the difference in the healthcare environment between Japan and the United States. The three big differences, the health insurance system and the device approval and the patient lesion character, they are very different. So the health insurance system is very unique. We have the universal coverage system, so the national health insurance for all the citizens. So high cost medical expense benefit system limits patient out-of-pocket cost. So the impact of this system to FT intervention is that the DCB, DES, atherectomy device, and imaging IVAS, they are very expensive products, but they all covered by the insurance. So device selection is based on purely on the lesion morphology, clinical evidence, and the operator strategy. So patient income does not affect the device choice. That's very unique thing in Japan. The patient cost for the peripheral intervention typically limited to the 500 to the 1,500 US dollar per month equivalent. Little bit difference depends on the insurance and the income, but limited. We have the very low limit. So most patients can pay this money for 1 month. So same therapy for rich and poor patients is performed. So device approval, the new medical devices are generally approved later in Japan than the United States. We have the time lag for the device approval. The sirolimus drug eluting is an exception. Maybe we have we can use before the United States, but most devices are delayed. So, and the Jetstream is the only atherectomy device approved in Japan. So, so we don't have other atherectomy device right now. And also, the usage of the jet stream is restricted to sufficient centers. So not all the centers can use jet stream. And the biggest difference and the very unique point of the Japanese initial system is that this is a bailout stent after drug-coated balloon is not approved. It's a very unique system. So usually in United States and European countries, many physicians perform the vessel preparation and deploy the DCB, and then they can decide we need bailout stent or not. But we have to decide the success of vessel preparation must be carefully assessed before DCB deployment. This is one unique thing in Japan. In the patient lesion characteristics, this is a Japanese all-comer DCB registries data over the more than 2,500 patients. Please see that the percentage of CKD without dialysis is 40%, and CKD on dialysis is 29%. It's an extremely high number compared to foreign other countries. This is a prospective registry, all-comer Japanese registry, drug-eluting stent, and also the percentage of dialysis is 28%, and the bilateral calcification is around more than 40%. So very high percentage of hemodialysis and calcified lesion patient. This is a Japanese prospective registry of the intra-uven super stent. The target is calcified lesion, so the percentage of dialysis more around 50%, extremely high percentage of CKD patients. So the patient characteristic in Japanese patient is a high frequency of the CKD, especially hemodialysis patients, a severe calcified lesion. So we have many problems. We don't have the atherectomy device, only the jet stream, and we have many calcified patients. So the specialty balloon are used at a high frequency in Japan. So we have these 4 specialty balloons: angioscalloped, urban cutting balloon, ultrasquare, and the Aperta NSE. So among these squaring balloons, the NSE has the highest integrated wire profile, so which allows for the strong squaring effect. Let's me share 2 cases. One case is this very diffuse SFA stenosis. This is actually the DCB lead stenosis. So, but this is a very diffuse and a small vessel. So I don't think this is good candidate for the stent or stent graft. So I want to treat this patient with DCB again, but this patient DCB failed at 1 year at the initial procedure. So we need more aggressive and good vessel preparation. So we use Aperta NSE 5 millimeter. We did not have this long balloon, but from this year we can start using this long NSE 100 millimeter. So we can use this balloon for this kind of long lesion, and we deployed another DCBs. And this is the final result of the angio. But you can see little bit dissection here, but you can see the very good result. We can use the intravascular image. This is an OCT image. We can compare. This is exactly the same section before and the post intervention. You can see very good dilation with very limited dissection. This is a pre-morphology, and this is a post-NSA and the DCB. You can see very good gain with very limited dissection. This is another section. We can see some filament squaring effect of the NSE, and this white spot is showing the DCB. And this is another slice. So you can see very good result at this moment. So, but the main problem of the specialty balloon is poor crossability. As you see, especially in the very severe calcified lesions, we sometimes have the hard time bringing this specialty balloon. So, but the NAC has we can use a unique technique in the NAC. This called leopard crawl technique. It's developed from the Japanese coronary intervention operators. So usually the balloon passes through most easily at the first attempt. And once it is dilated, its passability drops sharply. So we have to pass at the first time. So if you cannot cross the lesion at the initial stage, it is necessary to pre-dilate with another smaller balloon. However, even if NAC cannot pass completely through the lesion, expanding it at the point where it stops causes the integrated wire at the tip, this part of the balloon to expand, which widens the stenotic area and creates space for the balloon to advance. By pushing the balloon forward after initial dilation, it can progress further. So I'll show one case of this leopard crawl technique case. So this is a SFA, very severe calcified. Occlusion length is very small, but you can see very dark calcified at the occlusion site here. So I try to cross the lesion using O14 crosses penetration. It's a 60-gram tapered, very hard wire, but I cannot cross the lesion. I use a wire tail of this O14 wire, but could not cross. So I changed to the large O35 large focus guide wire tail. So this could advance like this inside of the calcium, like this. So using this space, I changes the O14 cross-lead penetration and finally success wire crossing. So since this is a very tight severe calcified lesion, I use a crosser IQ and I can bring the IVAS. These are distal stenotic points, some thrombus and plaque here. And here is a culprit lesion. You can see the wires crossing at the center, very, very severe calcified lesion. So in this situation, we sometimes want to use a jet stream atherectomy device, but I decided not to use jet stream. I tried to use only balloon angioplasty. And usually we need a small balloon, but this case, we bring a 6 millimeter Aperta, but cannot cross like this. Here is a calcified lesion, and we dilate and deflate and push. You can see here. Can you see the balloon crossing like this? So yes, here, stick here at this point, dilate, deflate, and push like this. So you can treat this kind of severe calcified lesions with only one balloon, the Aperta NAC. This is very good balloon for dilating this calcified lesion. And I finished with the DCB. And this is the final result. You can see very good dilation without atherectomy device. So this is the pre and post angiography, and the IVAS image, the 360-degree very calcified lesion, very clearly dilated with very multiple cracks here. So this distribution of the specialty balloon utilized in our hospital. Actually, more than 50% of the femoropopliteal cases, I use the specialty balloon. Among 4 kinds of the specialty balloon, I use more than 50%, and recently around 70% we use the NAC because of the very good squaring effect and as you saw the very good crossability. So in summary, the environment of the trend of the FP intervention differs substantially between Japan and the United States. In Japan, severe calcification is a major challenge. Non-slip element NAC plays a pivotal role in the FP intervention in Japan. Thank you very much for your kind attention.
Thank you for that very nice presentation. You know, it's been a pleasure when I go to Japan to work with many of your masters, which I've done in the past. It's been a lot of fun, and there are big differences. You know, in America, it's we have challenges having IVAS approved. We use it, but we think it's very important. But in America, it's something that insurers give us a little problems with, and the use of it is unfortunately not as much, in my opinion, as it should be. And I think sometimes these things do change practice patterns. Well, let's have just a little bit discussion about the differences. Certainly Japan is a small country in terms of population compared to the United States,
Yes.
has more people in dialysis than we have. Okay, in absolute numbers, and your basic patient base is older as well,
Yes,
which I
yes,
find,
yes.
and vessels are slightly smaller, not much
Yes,
smaller,
sure.
but certainly slightly smaller. A higher incidence of metabolic diseases, diabetes, and those things also, really do make a difference. I think that focal force balloons matter tremendously. I've been involved going back to really the very first focal force balloon that was really tried in the past, the original Burath balloon, and have used these. And one of the things I was always impressed with was that they did create a slightly bigger lumen at first, and I think these newer balloons are much better, but they tended to have less dissections, but they were incredibly difficult to deliver. And as you've shown here with this particular balloon, and I'm going to speak to it about the physics of the balloon in a second, but this balloon crosses actually quite easily. And the other thing it does is it rewraps. Once you use it, if you wish to then use it on other lesions, the rewrap is excellent. And I've found this to cross very easily. Now, one of the other differences between America and in Japan, almost all of your crossing is first tried with 14 thousandths wires.
Yes.
And albeit we use some of that here, we also use 35 thousandths wires sometimes. Or if we have done like you did with a 14 thousandths wire, we may have put, in that case, used an 035 support catheter with inside of that telescoping an 018 catheter.
Oh, I
Push
do
that first catheter across, then the second catheter across. And doing that, I am yet to see a case where Aperta would not cross if we were able to cross with an 035 support catheter, because that initial lumen seems to be enough to get things through. And certainly many of our patients are dialysis. Many of our patients, because we're a limb salvage center, have very hard lesions similar to what you're showing. But I've been totally impressed with this ability to cross as others. Would your colleagues want to comment on that, or my colleague Pradeep? Any comments, Pradeep?
Yeah, so the Aperta device that we've now had the pleasure of utilizing in our lab, it's really allowed us to treat a variety of lesions that otherwise with other devices we just could not get the equivalent results. So one of the most important points that I've noticed, and I'm going to show some cases of this, is that we can reuse it. And Dr. Walker had alluded to that point. There are other devices on the market right now that it is one and done. You inflate it and you remove the balloon, and it's very challenging to re-advance it because of the wrap. And this balloon allows us to utilize it on multiple occasions, multiple lesions, sometimes within the same case. And we have not had any issues with that. And the size matrix has been exceptional, especially with an 8 millimeter available for certain lesions, especially in the common femoral.
So in deference to our, because we still have a lot of things to cover, let's save some of the other discussion for a little later. But if we can go into my slides on the product information and what we're trying to achieve, please. So the Aperta balloon, next slide, please. My disclosures haven't changed. Next slide. So obviously, when we try to understand angioplasty, often Grunzig described it as like compressing snow. It's not that at all. It's plaque fracture, stretching of the vessel wall, and hopefully lumen expansion without creating massive dissection. Next slide, please. Now, the problem is that plaque is heterogeneous. It's not all the same. In those lesions that you showed earlier, some of those lesions would dilate very easily, some of the interposing areas, while others require much greater force. And when we would use long balloons, often one area would dilate very easily, another area all of a sudden at high pressures, you would see it suddenly expand, and that's not what we want with balloon angioplasty, because that results in dissections. So we want a slow, controlled opening. So pressure is what does this. And pressure is defined not by the pressure at the interactive elements with the vessel. It's defined by force per unit area. Now, by decreasing the cross-sectional area, in this case, of the wedges on the balloon, the tips of the wedges, by decreasing that cross-sectional area of the balloon that first touches the plaque, pressure is greatly concentrated because there's less area. Just like a knife, if we're sharpening a knife, we're decreasing that cross-sectional area. And this can be achieved by externally fixating blades, by external wire cages, by external wires, by nylon elements in this case. Now, what this allows for is slow, more gentle dilation that is controlled, and that results in less strain. Now, strain, if we think about that physics phenomenon, is how fast or rapidly we stretch something. And one can think of this with Play-Doh that children play with. If there's a ball of Play-Doh and we pull it slowly, it stretches. That's what we want. If we pull it apart very fast, it ruptures into two pieces. And that's what dissections are. Next slide. Now, bigger is better with angioplasty, and even minor changes in lumen make a big difference. But certainly, if we're going to ultimately follow this with a drug and hopefully not have intimal hyperplasia, we want as big a lumen as we can get. But we want to get there. We want to get there without massive dissections. Next slide. So why optimize balloon angioplasty? Well, it plays a critical role in almost all cases as either the definitive therapy or as preparation for stenting, or to further dilate post-atherectomy, or to deliver drugs. And we have drug elution balloons, of course. Shockwave balloon is a balloon being used in America, but it's expensive. It takes time. Its crossing profile is a little high. It's a great tool. And certainly we use it in certain areas, particularly in the iliac space. But then we have multiple focal force balloons. But I must state that the focal force balloon that I use by far and away the most is the Aperta balloon. And I didn't use it as long as many of these other balloons. Next slide. Now, the clinical challenges that we have when doing balloon angioplasty are highly calcified lesions, as you've shown, long occlusions, plaque involving bifurcations where plaque shift may occur, highly resistant lesions, and small below the knee vessels. But this is femoral popliteal talk. Next slide. So the mechanism of focal force, it creates controlled, in this case, longitudinal stress pattern in the same axis as blood flow. And that has been shown to cause higher stresses at the areas of the points that appear in a very localized region of the plaque. These high focal stresses allow slow, controlled vessel stretching to enhance lumen enlargement and diminish strain to decrease dissections. This results in larger mean lumen diameter, gain in efficiency, lower recoil, less injury. Next slide. Now, the Aperta balloon is shown here. Next slide. And the Aperta balloon, as you can see here on the image to the left, has four nylon elements, but these are not externally affixed. They're part of the balloon. This is monolithic construction. It's made as the balloon is made. And each of these nylon wedges on the balloon reach out 0.39 millimeters in height. In the smaller balloons, these are rated to 20 atmospheres. In the 7 and 8, up to 16 atmospheres of balloon pressure behind it, which is much higher than most other focal force balloons. Now, this balloon is very unique, though. It can be much longer than many of the other focal force balloons, but as these wedges interact with the plaque, they have a gripping effect. But that's very important because this balloon has a hydrophilic covering, hydrophilic coating, I should say. That allows it to slip through lesions more effectively. Now, as we start to expand, these wedges dig into the plaque, stopping the balloon from watermelon seeding. Very important to limit damage. And this allows us to not slip, to get good gain. Next slide, please. So we see here construction. The balloon comes from anywhere from 4 millimeters in diameter up to 8. Up to the 6 millimeter balloons, it can come as 4 centimeters long, 10 centimeters long, or 150 centimeter balloon length. And we can see here that the delivery length is 145 centimeters. All of these balloons can work over an 18 thousandths wire. Next slide. Here we see the 4 integrated elements, and notice these have 0.39 millimeters of height to them, and they're integrated and are part of the balloon. Now, what does that mean? Well, externally affixed agents can break off and embolize. This is part of the balloon. That will not happen. Next slide. So these are just a couple cases of areas where we'd really ideally not want to stent. This is a popliteal occlusion, and we can see 4 atmosphere dilation, no adjunctive therapy, the kind of outcomes that can occur with this. Next slide. And again, this is a focal lesion. It doesn't show here how calcified this was, but it was very calcified. Certainly, again, in an area we would ideally not want to stent. This was part of a treatment for critical ischemia. The infrapops were very severely diseased. And often we're using this, and this is our final therapy. Next slide. So conclusions on this balloon: monolithic construction, no risk of blade embolization. 4 focal force elements, which are 0.39 millimeters in height, which concentrate force. Non-compliant balloons on the smaller balloons rated up to 20 atmospheres. So remember, pressure is force per unit area. That's a lot of force. And we're really diminishing the area with these pointed wedges. There's low profile in hydrophilic coating, which gives us easy crossing. There's excellent rewrap, which allows us to reuse this and recross lesions. In my practice, I've seen less dissections, and that is not just as judged by angiography, but also as judged by IVUS. But I have to admit, we do not yet have randomized controlled data. We need that. Next slide, please. With that, I thank you, and we're going to go back to Dr. 𝐭𝐻𝐿. And Dr. 𝐭𝐻𝐿, actually, no, I'm sorry. I'm to present Dr. 𝐼𝐻𝐼𝐿. So Dr. 𝐼𝐻𝐼𝐿 is going to show a couple cases at this point, and then we'll go back to Dr. 𝐭𝐻𝐿, and you'll introduce your folks.
Thank you, Dr. Walker. I'm going to try to share my screen with you and just tell me, and just let me know if you can see the screen.
Got to put it on full.
Are you able to see the screen?
Not yet.
Okay.
Put it on. You got to click your little button.
Okay.
Over there, you see it.
Oh, wait a minute. They're not able to.
Got to hit share screen. You had share screen before. Share.
Yep, there we go.
Share at the bottom.
There we go.
Okay, here we go. And then
Yes,
full.
we can see the NSC balloon picture.
Okay.
Okay.
Very good.
Okay.
So I'm going to show a series of cases, and one of the variances that we see in the United States is that atherectomy is utilized. We have a very extensive experience utilizing laser atherectomy. Specifically, I'm going to be showing you some cases where we utilize it in conjunction with the Aperta balloon. So here are let me see if this can advance. Here's case number 1. This was a CLI Rutherford 5 patient, 76-year-old former smoker. He was a black male, had ischemic cardiomyopathy, multiple cardiac comorbidities, and he presented with ischemic rest pain of the left foot, and as well as ischemic ulcers on his first, second, and fifth digit, as you can see in the slide. the patient quit smoking in the remote past. He was not diabetic, and you can see these are the medications he was taking. Really was not on a really good cardiac regimen, to be quite honest, with his history of cardiomyopathy. So this is the patient's angiogram, the initial angiogram that you can see. These are actually cases that I did live for various conference. The 3 cases I'm going to show you are cases I did for some conferences. This patient had a SFA that had some diffuse disease. You can see that at the tibio-peroneal trunk distal popliteal, there was an occlusion with reconstitution that you can see here in the foot, the dominant vessel being the peroneal that was filling via collateralization with the posterior tibial artery filling late. So we utilize intravascular ultrasound, and all of these cases were done at our ambulatory surgery center. These are at our ambulatory surgery center. We utilize IVUS quite frequently, typically for every case. And I find IVUS to be extremely helpful in identifying plaque morphology, vessel size, and help to determine the best adjunctive therapy that we need for the patient. And you can see in that femoropopliteal segment, there was significant stenotic disease. It looked like a mixed plaque morphology overall, with a vessel diameter that was roughly 5.5 to nearly 6 millimeters. And so in this case, we did not choose atherectomy in the SFA. It was a mixed plaque morphology. Other issue for atherectomy was the infrapopliteal flow was quite poor. We were concerned about distal embolization if we did choose atherectomy in this case, potentially worsening the flow because of the outflow in the foot. So we used an Aperta balloon. This was a 5 millimeter by 150 millimeter Aperta. And you can see quite clearly that this is just straight with the Aperta balloon. You can see all of the lesions were easily dilating with this balloon fully throughout the SFA popliteal segment. And so you can see on the slides on the left, the disease segment, and the slides on the right, the vessel. We treated that with a drug-coated balloon at the end, and we achieved a good result. So after the Aperta balloon was utilized, again, you can see the original stenotic area and the post-Aperta vessel luminal gain was quite significant. And so then we turned our attention to the distal popliteal tibio-peroneal trunk and popliteal. And in this case, we opted for laser atherectomy to treat. Now that we got the inflow treated, we used a laser. And this is a treatment, what you can see is post-laser. It looked fairly hazy on intravascular ultrasound. It was actually not dissected. These were all eccentric plaques that you can see. But we used an Aperta, a 4 millimeter by 40 millimeter Aperta in the distal popliteal posterior tibial artery. And then, as we mentioned, this is a balloon that easily rewraps. We were able to remove it and then insert it into the peroneal vessel without any issues. And this is the type of results that you can get with this balloon that we found in our experience. So this was not requiring any stent. I did finish it with a drug-coated balloon in the posterior tibial distal popliteal, but we were able to achieve a very good luminal gain. And then we moved on to the pedal vessels, and you can see we went through the posterior tibial artery around the pedal loop. And in this case, we did a controlled antegrade, retrograde, subintimal tracking procedure to recanalize the anterior tibial artery, and we're then able to restore flow to this patient's foot. So that was case 1. This is case 2. This was another case that we did live. This was another chronic limb-threatening ischemia patient, 62-year-old female. This patient was diabetic, had Rutherford 5 ulcer on the hallux. This patient's wound developed months earlier, and one of the issues we deal with in the United States, and I'm wondering in Japan if it's the same, is oftentimes PAD is misdiagnosed or not diagnosed early enough, and this was one of those patients that was not diagnosed earlier. There was a delay in vascular referral, and the patient's wound was initially looking like this, but was continuously getting worse with a reduced ABI. And this patient had an occluded mid to distal SFA with reconstitution in the popliteal segment, and it was heavily calcified. And so you can see the calcification on the far right. There was an extensive disease. The SFA was occluded. There was an island of reconstitution with yet another occlusion with reconstitution distally. The tibial vessels, there was some moderate disease, you can see, but there was flow filling the foot. So in this case, we came from a contralateral femoral approach and attempted to cross. We still also try to do true luminal crossing. I would love to learn from the masters. We utilize cross-lead penetration as well, but it would also not cross. And so in this case, we opted to go subintimal from an antegrade approach, but our wire, this was a Gladius Mongo 18,000s type wire that we were advancing from the top, would not cross. And so in that case, we come from a retrograde tibial approach, and you can see the wire continues to go subintimal despite attempting a true lumen cross with a variety of wires and catheters. And so in this scenario, with this patient, we performed a 𝐼𝐸 procedure yet again, and you can see we were able to then enter the true lumen. Where the calcification was noted was where we were having the substantial difficulty in crossing, but then we were ultimately able to cross. And so in this case, we know when we're doing a 𝐼𝐸 procedure that there is going to be stenting that is going to be required. We still utilize atherectomy in these forms, in these types of cases, and in such, we used a laser, 308 nanometer laser, and followed by the plan for stenting. And in the Hunter's canal, distal popliteal, in the popliteal and Hunter's canal, we oftentimes, and calcified disease, we typically are looking for woven nitinol stents that have limited fracture rates. Supera has been our go-to stent in these scenarios. And so what we ended up to do for the Supera stent, very important, is prepping the vessel adequately. A poor prep of the vessel prior to deployment of a Supera can lead to very poor deployment of the stent, which could lead to very high restenosis rates. But in this case, we used a 6 millimeter Aperta balloon. We're able to easily dilate the vessel and then follow it up with a 6 millimeter Supera stent, and we were able to achieve a good result. The final case I'll show you was an 86-year-old gentleman. This is a gentleman who had mixed venous and arterial disease. He fractured his leg. He was known to have PAD for many years and was treated medically. After his fracture of the leg, he was found to have an extensive DVT in his left leg with substantial occlusion extending from the popliteal to the iliac vein. He had substantial edema, stasis, and we opted to treat the venous occlusion first. Oftentimes when there is mixed venous and arterial disease, I go for the arterial disease first, but in this gentleman, opted to treat the venous disease because of the extensive thrombus noted. And we were able to get the edema down in his leg and then proceed to treatment of his arterial wounds. Again, this is post-operatively after he had a leg fracture with multiple surgeries. He had a wound on his dorsal foot, he had a wound on his lateral foot and in the Achilles. And you can see our venous stent in place. That was an occluded iliac vein that we recanalized. He had disease in the common femoral artery on the left, highly tortuous iliac vessels, and an occluded SFA that reconstituted distally. And so in this patient, you can see the prosthesis with the fracture. His tibial vessel was dominant from the perineal, which recanalized into the foot via collateralization. This is the common femoral artery on IVUS. You can see there was a significant stenosis with calcification. And I want to show you what the vessel looked like after we treated it with an Aperta balloon, which I'm going to show you. So this is pre on the left and post on the right, 8 millimeter by 40 millimeter Aperta that we were able to open up this common femoral artery with. And then we proceeded to open up and recanalize. And here you can see the final result. And now we've focused our attention on the SFA. And this is, again, the picture of the common femoral artery pre and post. And with the SFA treatment, we again were crossing from above, required a retrograde approach from the posterior tibial artery. In this case, we again performed a 𝐼𝐸 procedure, were able to externalize the wire and had a floss in place. and utilized again a 6 millimeter by 150 millimeter Aperta balloon for vessel preparation in anticipation for again, another Supera stent. And the balloon works phenomenally well in vessel preparation. And again, here is an example of where we then place the Supera with a very good result. And you can see the IVUS post stenting. And so those are the three cases, and I look forward to discussion at the end.
So Pradeep, certainly with poor preparation in calcified vessels, Supera does not do well. With good preparation, it does superbly well. And the long-term results that came from the trial called Superb, and I think that's why it was named that. I sat on the board of directors of that company as in its development phase. I think those results were, to this point, nothing has come close to that in the popliteal section, particularly in calcified lesions. Any comments from our Japanese colleagues about
Yeah,
some
thank you very much.
cases?
Yeah, impressed with the very good cases and presentation. So, any comments from Dr. Toyoshima?
Thank you, Dr. Kozaki and Dr. Walker, Dr. Nair. It's my pleasure to be here. My question is about vessel preparation before going to the stent or going to the DCB. We cannot use the IVL now. It is on the clinical trials session. So my question is about which way to go to the specialty balloon like the Aperta, or go with the IVL, or go with the atherectomy like the jet stream or the laser atherectomy. How do you choose in calcified lesion, especially?
Yeah, to be honest, we don't truly know yet. One thing that IVL does have is data. And the Disrupt 3 trial did show some patency benefit for sure. It has limitations, as I've mentioned before. Its expense is one limitation. A second limitation is its crossability. And certainly when we're treating bilateral iliac disease, that's a problem. I know this is for today is the femoropopliteal segment. But as we get into the femoropopliteal segment, we really don't have comparative data. I will tell you, I've seen very nice results with shockwave balloons, but I've also seen incredible outcomes with this focal force balloon. I'm very intrigued by this balloon. Its ability to cross, I think it behaves like no other focal force that I've used. And I've used focal force since the first focal force balloon that was out. And I was involved a little bit in the development of some of the other focal force balloons. But I think that the jury's out on when do we use each of those. Perhaps that would make for a good trial. Pradeep, any comments?
Yes. So in fairness, in the United States also, we have all the atherectomy tools available to us. So that's one aspect of what I'm about to say. So for example, if we choose a laser, there's various properties, light pulse, acoustic waves, which can help with the calcification. IVL, we're helping to change the compliance. But when we utilize IVUS and we look in a vessel in a femoropopliteal segment that's calcified, we oftentimes see calcium, and then we see mixed plaque morphology in between. And there's oftentimes in a segment of femoropopliteal disease, we just see a whole host of various disease processes that are occurring. But if I did not have ability to utilize any of those atherectomy tools, I think the Aperta balloon, utilizing the concept of strain rate that Dr. Walker had mentioned earlier, a slow inflation, a longer inflation, can help to really crack those lesions, those calcified, because we used to do that in the iliac vessels. Whenever we were treating iliac disease that was heavily calcified pre-IVL, we would take a balloon, we would be able to just go slowly on the balloon until that vessel was able to fully dilate. So I think it is doable, and I think a specialty balloon or a focal force balloon in that scenario would come in exceedingly helpful.
Now, I have one question. You've mentioned you only have one atherectomy tool. Do you not have laser for use in in-stent restenosis or in-stent occlusion? Because I really think that's the standard of care. I've presented before the Japanese FDA, not on that, but I've presented on other things in the past. It seems like, if we look at the EXCITE trial, use of laser to first clean out some of the old thrombus in that occlusion, some of the neointimal hyperplasia, and following that with a drug-coated balloon, if we look at some of the work of Vandenberg, but also Gondini, resulted in incredibly high patency rates if one was able to first clean with laser and then subsequently follow with DCB. Do you have access to laser for that?
Yes. But only for the in-stent restenosis and occlusion. So I was impressed that Dr. Nair shows the 3 cases of the laser in the de novo lesions. So how in cases of the calcified lesion, is that we can use a laser in de novo lesion in coronary artery, but the percentage of the usage is very low because of the low crossability, and also in coronary artery we have the low tabulator and the orbital atherectomy.
Yeah.
So how do you select the lesions which is very good for not instant in the for laser?
Let me answer that question because we actually have 2 lasers now available. One is 355 nanometer laser, and one is 308 nanometer, which was the one that has been present the longest. Now, they're somewhat different because 308 is given in relatively long pulse durations. And the pulse duration of 355 is very, very short. It's on the average around 16 milliseconds. The other is much, much higher. Both of those lasers are off more than they're on. Now, historically, it was taught laser did not do very much with calcium. However, laser itself, excimer laser itself, would cut through bone. The problem was the cladding, and we could not negate that. Well, 2 things have changed. One, the 355 nanometer laser with these short, very high amplitude bursts does seem to have a major acoustic shock wave associated with that. In fact, some of the new shock wave balloons are being driven by laser. And so there is an acoustic shock wave that occurs. Now, that acoustic shock wave can also occur with 308 nanometer excimer laser, but it's greatly magnified with 308 if one introduces calcium. And there's a trial going on right now called the Thor trial, in which contrast is used, because that contrast amplifies that photoacoustic effect. So many believe there may be a shockwave-like effect with laser. But the other reason we would use laser, what laser is also incredibly effective with, is both old and new thrombus. And we believe that that plays a major role in embolization. And embolization is really a curse in peripheral vascular interventions. And so that's the other reason that we utilize it. There is one final reason. We think it takes much less radiation to use this, because if we've crossed with a wire, with almost every other atherectomy tool, excuse me just a second. With every other atherectomy tool, we have to watch it on fluoroscopy. Laser, we don't. In very long lesions, because we know where it's going, we just temporarily tap. So we would use it in those cases. And then there's one final thing. Albeit I think every atherectomy tool works better with true luminal crossing. As you know, sometimes that's unachievable. And if we're going to use an atherectomy tool and perhaps get some of this photoacoustic effect, because also shockwave doesn't work as well in a subintimal space, we like laser in that case because it does help us carve out a channel. So that's a long-winded answer, but for a very important question.
Also, I have one question that the position of the jet stream in the United States. That's because the jet stream is the only atherectomy device in Japan, so many physicians now use the jet stream. And Dr. 𝐭𝐻𝐼 have reported that the very high frequency of distal embolism, it's a very big problem in Japan. So how in United States, the position of the jet stream, which region are you using?
Yeah, so I think Jetstream has been, it's a good tool. The issue that I've seen is what you just mentioned is at times distal embolization. So invariably what I utilize is a filter whenever possible now, utilizing Jetstream. And in fairness, when I utilize a laser, if the key is to go slow. And if you go slow with a laser, the distal embolization rate is less, in my opinion. So our experience has been really shifted heavily into, if we're choosing atherectomy, laser atherectomy. But conjunctively, whenever you look at this in a long SFA CTO, and if we're thinking about stenting, creating that channel is very important, especially if you're going subintimal, true lumen, subintimal, back to the true lumen. The laser is able to clean out one channel, and I only feel comfortable using a laser in the subintimal channel, as Dr. Walker said, but then following it with some form of focal force in calcified lesions specifically, so that I can get the best luminal gain possible.
Yeah, I think we've underestimated distal embolization in these interventions all the time. I think we always have some, but we want to make it as little as possible. We want to make it not as clinically significant. And so I think it does play a role. Now, he used the word slow advancement of laser. Let me define that. Ideally, that should be probably 0.5 millimeters a second. Most people don't do that. Most people want to go very fast, and it doesn't work that way. So if you're going to use laser, you have to use it right. Just like a hammer is a great tool for driving a nail, but it's not real good to clean your teeth. You have to use the device the way that it's intended to work. Okay?
Yes, okay, thanks.
Okay. Yeah, if no other questions, Dr. 𝐭𝐿𝐤, perhaps we can have Dr. 𝐭𝐿𝐤, your colleague here, do his case presentations. Is that okay with you?
Yes.
Okay. Pretty sure.
Dr. 𝐭𝐿𝐤?
Okay, yeah. Can you hear me?
We hear you just well. Fine.
Slides. Yeah, okay. Just a moment. I'm just sharing my slides and just want to share. Make sure you can see my slides.
Okay.
Very well.
Can you?
Okay. Yes, very well.
So thank you very much for having me to have a talk. Actually, some of my presentation overlap with previous doctors' contents, but I'm going to have a talk from my perspective. So let's say preparation using the NSC. Notice. So suppose you have a good looking potato in front of you. How would you eat it? This is my first question. So if it's muddy, I'm sure you don't want it, and just putting the butter on the top is not enough. So it's only perfect. It's good when the butter soak deep inside potato. This is actually the concept behind using a scoring balloon, and I think this concept connect to Dr. Walker's presentation. I think. Are you agree with me?
Yes, I like this.
So this is a kind of same slide from Dr. Kozuki, and this is data from Japanese JEBT data 2024. So before we used to use diameter stain and plain balloon angioplasty, but with the progress of the drug technology, we started using the DCB and DES like this, and now over I think 60% we use actually DCB, so leave nothing strategy concept. So, but the effect of DCB just drops when it comes to calcified lesion. So a calcified lesion leads to incomplete expansion, and calcified vessel interfere drug penetrating into a vessel wall. And now by using a squatting balloon, you can improve vessel expansion and the subsequent drug effect, as Dr. Walker presented. And this is the SKY consensus guideline for device selection in FE interventions. Specialty balloons are located as a lesion preparation, and then especially recommend using a specialty balloon in two parts. So when you can't dilate a vessel very well, or when you see the really calcified lesion. And this is a kind of recently uploaded on the paper. So regarding the algorithm for the endovascular treatment for FP lesions, if you see the table, you have on the top you have a lesion preparation and definitive treatment, and also on the left you have on the main lesion characteristics. And if you see the middle, we have specialty balloon here, but a part of lesion preparation, and then they have two main indications for specialty balloon. The first, mobile segment, including an SFA distal or popliteal artery, so where you want to avoid stenting or scaffold. So by using a scoring balloon, you can achieve less recoil and less direct dissection. And number two is same as on the SCAI guideline, severe uncalcified lesion. So you can improve vessel compliance by making control crack and enhance drug delivery, which I'm gonna present later. So let me show you one example. This is the PAX4 calcified SFA lesion from ostium SFA to down to a distal SFA. For this kind of lesion, I usually, I always use an NSC squatting balloon. And for this case, I actually use a 5mm NSC balloon. And then, especially for the really calcified lesion, I did multiple inflation to make more control cracks. And after that, we did a short and a really robust the flow, and I was confirmed adequate vessel lumen and multiple initial cracks. So which imply we can improve vessel compliance. So and then we did the non-compressible balloon, 6mm balloon dilatation, and then we finished with a 6mm balloon DCB, and this is the final shot. So multiple inflations, like I said, can create cracks in multiple directions. So you do a 1, 2, 3 inflation, that you have really multiple cracks in many directions. So now let's compare with the NSC with other scoring balloon. As Dr. 𝐭𝐻𝐿 already mentioned, among them, the NSC has the tallest elements, and these elements are made of nylon instead of metal. And the tips are really sharp. So when you inflate it, these elements can reach the calcium intima more easily and create initial cracks we're aiming for. So I show you how NSC balloon works for calcified lesions. So suppose we have a vessel and with intimal calcification, and you're going to use an NSC for those lesions. What's going to happen? So when you inflate the NSC balloon, the element push into intima and making cracks. So this is number one, like here. And by keeping inflation, the force actually spread between the element, and you can actually make a tear between them. So actually you have two mechanisms. You can, make a cracks by element, and also you can make a tear between them. And also I believe NSA works better for circumferential calcifications. For example, the vessel with a 270 degrees of calcification. And you do on the NSC ballooning, you can, multiple elements can engage calcium and making multiple cracks. But if you have, let's say, calcium arc is about 90 or 100 degrees, only one or two elements contact calcium, and force actually go toward the non-calcium side, this is the softer side, and leading to severe dissection instead of control cracks. So going back to the issues we have, where we treat calcified FE lesion, by using squatting balloon, you can create cracks and improve vessel compliance for efficient lumen gain. And then by reducing need for aggressive dilatation, you can achieve fewer dissection and less recoil. And finally, you can improve DCB contact area and promote deeper, longer drug penetration. I show you one interesting pathology paper. This paper is about how a cutting balloon, a specialty balloon, enhance drug effect when you use a DCB in the rabbit model. So this the paper showed the smooth muscle cell just missing at exactly same spot of the plaque formation. So this indicated crack formation enhance drug penetration by pathology. And now, we have longer version of NSAs available, so 100 and 150. So if you look at the previous DCB data, compare trial and popcorn registry from Japan, the mean length, lesion length, around like 120 or 130. So, which means you can cover entire lesion in single inflation if you use a 100 or 150 balloon, NSC balloon. And you can reduce the risk of dissection and shorten the procedure time. This is really important. So simple procedure is best, I think. So let me give you another example. Just last month, we treated 350 millimeter FP lesion with a heavy calcification from ostium SFA to popliteal artery, involving the mobile segment, distal SFA and popliteal artery. I wanted to avoid using the scaffold, so I used NSC for this lesion. Sorry, yeah, and I use an Aperta NSC 5 or 0 by 100, and we did a dilatation. If you use 40 millimeter, but instead we would have to need it 2 or 3 times more inflation. So followed by a non-combined balloon, 6 millimeter, and finish with DCB, and this is a final shot. It's really beautiful, excellent flow. And after that, CFA was treated with endotracheotomy. So based on everything I talked about today, let me show you how I treat calcified lesion in daily practice. So in severe calcified lesion, down to a popliteal artery like this, most of us would want to avoid placing stent. So this is the flow. And so after guideline crossing, and in many cases, I routinely use an IVUS in this complex lesion to assess vessel morphology and wire position. And if I need it, we add atherectomy or IVL, depending on the lesion characteristics. And now it comes to vessel dilatation. I choose a specialty balloon to create control cracks and improve the drug penetration, just like a butter to soak deep in the potato. And for short lesion, I let's say less than about 100 millimeter, 40 millimeter NSC is usually enough. But for a longer lesion, 100 or even 150 millimeter works better. So lesion is, the reason is simple. We want to minimize the number of inflations, and keeping a procedure simple is always better for EVT. And so naturally for a long lesion, a longer NSC balloon makes sense. And finally, once vessel is well prepared, we finish the case with DCB. So in conclusion, NSC works really well in calcified FP lesions by creating control cracks, which help the drug travel deeper into a vessel wall. And now longer NSC is available. You can cover long lesion with just 1 or 2 inflations, which keeps the procedure simple. Thank you for your attention.
Thank you. That was a great presentation. Watching that potato, it made me think of how much I enjoyed your Wagyu beef when I was in Japan. But to go with that. But great talk. And I understand what the consensus statements say about we should use this in non-dilatable lesions or other things, but I'm not sure I agree with that, if I were to be completely honest. Because I'm not so certain that if we inflate very slowly, and if we can keep pressures very low, and if indeed we can create controlled cracks, that we may not routinely get better expansion of even non-calcified vessels. But let's also talk about calcium. But I think these deeper tracts might facilitate better drug transfer when we follow with a drug-coated balloon. I don't know that. We don't have a trial for that. Nor do we have a trial even just showing how much bigger the lumen is and how much less the dissections are. But it's a trial that I think should and must be done, because I think what we would see is much greater lumen expansion in this. And, you know, as we speak about DCBs, we've heard often, I heard often in the early days of DCB, and I disagreed with it even at the time. It was an unpopular disagreement where people said, well, even if you have what looks like a high-grade stenosis, the drug will fix that over time. It does not. The drug only stops intimal ingrowth. It doesn't open the vessel. We have to open the vessel ideally. And I really wonder if we're underutilizing focal force, if it might not be better in most circumstances with that. Pradeep, any comments?
Yeah, so I love the presentation and I love the algorithm. You know, I remember Dr. Kozuski's presentation mentioned in Japan. There is no, there's no reimbursement or something. I remember you mentioning after bailout stenting after a drug-coated balloon, right?
Right.
So the algorithm that I've been employing here, because the Aperta balloon has been really inflating the vessels very well, I've had we utilize drug-coated balloons quite often. And after I utilize the Aperta balloon, the only variance that I have is I go straight to the drug-coated balloon, and I get very good results with that. So in the algorithm that you had, the only one that I skip typically is the non-compliant after the Aperta. What about you, Dr. Walker?
It depends on what my vessel looks like. And you know, the other question here is, do we still need yet longer? You're treating 30 centimeter lesions here sometimes. Should we ultimately make one of these balloons longer? You couldn't do that with a regular balloon because there'd be so much dissimilar force between soft areas and hard areas. But with this and with the magnification of pressure at these short points, and these are linear, they're extending the entire length of the balloon, might we benefit if we had a really long balloon that we could take up slowly and leave up for several minutes, perhaps 4 or 5 minutes rather than multiple inflations? Because the second physics phenomenon that we're trying to grab is that of plasticity. When we hold the vessel open when we hold something in a certain position for a long time, it tends to stay in that position. Like if we take a toothpick and bend it, it snaps right back. But if we hold it that way for a day, it does not. That's plasticity. And, plasticity does play a role in angioplasty as well. I mean, I really salute the fact that they've made this 150, which is great for a focal force balloon. But I would strongly encourage the company, because you can make this in a mold now with these wedges, to create yet longer balloons. And I bet my colleagues in Japan would agree with this as well.
Yes, very agree. Yes, 30 millimeter, 300 millimeter balloon we need. Yes.
And in one other respect, the circumferential calcification and the medial calcification we see so often in the tibial vessels. And one day when we can get it to the size of a 3 millimeter, that'll be a game changer when we treat tibial disease.
May even be more important there. It's important here, but maybe even more there.
Yes.
Other comments from your colleagues?
Can I ask you one question?
Okay. Please.
So the question to the Walker and the Nair. So regarding the practical use of NSC. So for example, when you use the NSC for mobile section, like distal SFA or papillary lesion, where you want to avoid using the stenting or scaffold, versus when you use them for like proximal or mid SFA, you don't care, stenting. So do you differentiate like the sizing and the pressure inflation pressure depends on the lesion?
First off, I'm not sure I would only use it in the mobile section. And I think I have even seen proximal stents fracture. It's much less than distal stents. And if I can get by with a good result that lasts, and I think drug-coated balloons, and I'm optimistic maybe maybe that the Med-Alliance balloon might yet give us yet better. We'll see what happens. Some of the early data looks promising. If we could first get ideal balloon angioplasty and follow with that, and if we could get by without stenting, I think that would be a win. And even the not in the mobile section. Pradeep?
Yeah. No, I agree. I think our processes, specifically in our laboratory. I mean, in many laboratories now, intravascular ultrasound is really the eyes of what we do. It helps us provide a precise intervention to these patients, especially in the mobile segments. A mobile segment that's a CTO that you had to cross, and you think you're in the true lumen, but you're actually now maybe in a subintimal plane. There may be unavoidable to stent. But in those scenarios, I really avoid any self-expanding nitinol stents. I use the woven nitinol stents in the mobile zone if a stent is required. However, I think this is an area where focal force balloon, IVUS, and then also drug-coated balloons were going to be extremely helpful to try to avoid stenting in the mobile segments.
I agree. I think we're going to have to go on to just our final points. I can't tell you how much I've enjoyed this. I enjoy the collaboration. I've always enjoyed working with my Japanese counterparts. You do great work, and I love visiting your country. It's been a lot of fun. Obviously, I want to thank 𝐵PRO for making this balloon. It's a whole novel concept. It's allowed us to treat some patients, I think, more effectively than before. I look forward to further collaboration where in your places where you can use IVUS much more readily than we can. Often, like in our ASCs, it's just simply we are not paid for it. It's stuff that we have to pay, and we'll actually lose money out of our pocket on those cases. Not make more, but actually lose money per case. And so we sometimes can't use it, even though we would like to. But I think it's incumbent upon us to show what this does in terms of luminal gain, what this does perhaps in terms of drug uptake, what impact this has on restenotic phenomena, and what impact it has on our ability to ultimately deliver things like a Superis stent. I'm certainly optimistic this may help, but I think we need more data, and I look forward to working with you on some projects to hopefully answer those questions. Any other closing comments from our distinguished panel here? If none, I think that we are running out of time. I want to thank each and every one of you. This was, I think, a very nice session. I want to thank Tim Hill and 𝐵PRO for arranging this. And certainly I look forward to more collaboration as we move forward. Thank you very much.
Thank you very much.
Thank you all for participating tonight and this morning. We really appreciate it, and we thought the discussion was wonderful. And we want to thank our attendees and our presenters for taking time out of their busy schedules to share all this wonderful knowledge. Thank you.
Okay. Bye-bye.
Okay, thank you.